So hopefully this will add to what we've had already. One thing I'm going to do here as I talk about the role of empathy in nursing, I have a discussion of where a phenomenologist called basic empathy and its contrast with emotional and cognitive empathy, but I know that some of the other talks have already discussed this as well. So I don't want to have too much repetition for those of you who have already viewed some of the earlier presentations over the last few weeks. So I'm going to actually kind of reorient the talk a little bit and spend a bit more time just giving you a sense of how it is that empathy is conceptualized and used within the field of nursing. And then the last 10 minutes or so, we'll get to this discussion again of emotional and cognitive empathy as it's developed within psychology, and then a phenomenological alternative using basic empathy and how that might be relevant or important for nursing. And I also want to clarify here, the material that I'm discussing is primarily from some collaborative work that I've done recently with Dan Zahavi that's come out in a series of articles. A couple of them have come out in nursing journals, and one's recently come out in a philosophy journal. But we have this work on the role that basic empathy might play in nursing research, nursing practice, and nursing training. Okay, so let's start by just talking about the role of empathy in nursing, right? What role does it play here? So if you look at the nursing scholarship, and if you also just speak with nurses, it becomes pretty clear that many nursing scholars, many practicing nurses, maybe even the vast majority of them, agree that empathy is something that's key to effective nursing practice, right? That you wouldn't be able to be a competent or effective nurse if you didn't have empathy, or if you didn't empathize with your patients. And this actually differs from the way some other fields within medicine kind of conceptualize themselves or think about themselves and think about the role of empathy. So you don't see the same kind of hyper focus on empathy among physicians, for instance, in medical school. So there's sometimes concerns about the extent to which a physician might actually lose empathy over the course of their career, whereas it seems like within nursing programs, there's an emphasis on one's ability to maintain a kind of empathic approach. Now, despite the fact that nurses tend to agree that empathy is key to effective nursing practice, there's a sense in which the concept is still immature. And I'm using this term immature in the way that nursing scholars use the term. So there's a whole practice of what's called concept analysis and concept development that's used in a variety of fields, but has been very popular within nursing, or at least used to be. And one of the ideas here is that concepts can exist at various levels of maturity. And they've pointed out that empathy, despite how important it is for nursing and how widespread the use of this concept is within nursing research and practice and education, it's still not particularly well developed, right? Which there's a few different things they mean when they say that this concept is immature. So on the one hand, the concept can be immature because the division between this concept and related concepts is not especially clear. So in the case of empathy, similar concepts might be things like sympathy and compassion. And ideally, we'd hope that we've defined empathy in such a way that it's very clear how it differs from sympathy, how it differs from compassion, despite the fact that they do share some similarities. Now, one of the problems is that in the nursing literature, empathy is used in such a wide variety of ways, or the concept is used in such a wide variety of ways, that sometimes we can't adequately distinguish it from things like sympathy and compassion. So that's one sense in which the concept is immature. Concepts can also be immature because they refer to a variety of phenomena rather than having one kind of distinct object that they refer to. Right? So we might use empathy in this kind of broad or generic way that actually refers to a few different phenomena that ideally we should be able to better distinguish. And then also, because nursing is, of course, a scientific discipline, there's, I guess, if you put maturity at various levels, the highest level of maturity for a concept is typically a case in which you can measure the concept, ideally in some kind of quantitative way, for instance, having some kind of scale that you might use in the course of, say, doing interviews or observing the way in which nurses interact with patients. You should be able to rate the level of empathy someone has, ideally. So I'm not going to get into further discussions about the extent to which the concept of empathy should be something that we can measure in that respect. That's kind of out of the scope of my own research. But I think that once we recognize that some of these concepts within the field of nursing kind of suffer from a level of immaturity, then it seems natural that we might appeal to philosophy at this point, right? Because one of the things that philosophy does well is clarify its concepts. So the general idea here is to say, look, there's a concept that's very important for nursing, but within the nursing scholarship, it still has not been well defined and well articulated. So why don't we fall back on philosophy and see if philosophy has some resources that we can use in order to make this concept more mature within the field of nursing. So I'm going to talk about some of the ways we go about that and some of the challenges of doing that kind of work. And again, one of the reasons why we might want to do this, not just for our own kind of philosophical satisfaction of clarifying a concept, but especially if you look at some of the nursing literature on training and education, it's common to point out that nursing training programs should involve some kind of component where empathy is trained or taught, or one's taught how to empathize in more effective ways or to express their empathy in more effective ways, depending on how you characterize it. But one concern that you continually see throughout this literature is that despite the fact that nurses do want to have this kind of training, if they haven't quite clarified what exactly they mean by empathy, then it's not entirely clear, first of all, whether empathy is the kind of thing that can be trained. And second, if it can be trained, what it would mean to train empathy. So we'll get into that discussion later on as well. Okay, so to get a sense of kind of why the concepts of empathy within nursing remain immature and why they haven't been able to be as effective or accurate as they were hoping, it'll be helpful to look at how exactly the concept has entered the field of nursing in the first place. So nursing is a particularly interesting kind of case study here of looking at concept development within the sciences, because unlike many other scientific fields, nursing as a research field and as an academic discipline is fairly recent. It has a very short history. So of course, there have always been people who have played the role of a nurse, I guess. And nursing as a practical professional role has roots that at least go back to the 1800s. But nursing as an academic field and as a research field, history kind of differs from one country to another. But for the most part, the major departments of nursing within universities got their start around the 1950s, even 1960s. So it's a fairly recent history. And that means that over the span of a few decades at the beginning, they had to go through what we sometimes refer to as things like paradigm shifts, where there are certain crises of disciplinary identity, we can say, right? So all of these nurses or nursing scholars and nursing researchers begin doing work, and they need to figure out to what extent is nursing as a field kind of best situated within, say, the medical sciences, alongside things like physiology and pathology and so on, or is it situated within the social sciences or even some other kind of field? And depending on how you identify the field of nursing and which fields you think are kind of cognate fields or fields that are very similar to the field of nursing, then that opens the door to saying, okay, well, if nursing is similar to this field, then we can look to that field for theoretical foundations, and we can take that field's methods, and we can use them in our own field. And there's a whole history of these debates going back and forth, and some fairly substantial changes in how nursing researchers understood their discipline, what they considered their role to be, what they thought the relationship was between nursing research and nursing practice. And there's a very interesting history here that I won't go into in any detail. But one issue is that because it kind of got started so quickly and so recently, right, it's not the kind of field where they have hundreds of years of history to begin designing and developing and refining their own concepts. Often, right, they had problems they had to solve immediately. And the most effective way to do that, or the most efficient way to do it, I guess is better to say, is by borrowing concepts from other disciplines that look like they'll do the work they need to do. So nurses have borrowed concepts from a wide variety of disciplines, including disciplines like psychotherapy, psychology, and the cognitive and affective neurosciences, to some extent also philosophy. Depending on what kind of research they're doing, they might also borrow from areas like sociology or anthropology. but there are a wide variety of disciplines where they kind of borrow and adapt concepts from. So many of the concepts within nursing did not originate in nursing, and they're very clear about this. And because the history is so recent, for various concepts, you can sometimes even trace it back and find out where exactly the concept originally came from within nursing, right? Where was it first borrowed from? How did it enter the field of nursing, and how did it develop from there? So it's also interesting to look at how the concept of empathy has changed over time within the field of nursing. So one of the earliest influences on how nurses conceptualized or understood empathy came from Carl Rogers' concept of therapeutic empathy. So Carl Rogers is a famous psychotherapist, and he wrote a number of books about psychotherapy, and he clarified and introduced a number of concepts that were important for understanding the nature of psychotherapy, what it meant to be a psychotherapist, and the nature of psychotherapeutic practice, including the relationship between the psychotherapist and their patient or client. So the reason that Rogers' work had such a huge influence on nursing is because in 1959, he was invited to give a keynote speech at the American Nurses Association. So again, 59 is very early on in the history of nursing as a research field. So he was able to kind of give this keynote speech at a very formative moment in the development of nursing as a field or as an academic discipline. And he presented his concepts as fitting within what he called a client-centered approach. And that resonated with a lot of the nurses in the audience who took themselves to be using some kind of patient-centered approach. So it seemed like the concepts that Rogers was introducing that were clearly applicable in psychotherapy could easily be kind of transposed or reintroduced into nursing. So I'll just give you here one quote to kind of introduce how Rogers thinks about his own concept here. He says, the state of empathy or being empathic is to perceive the internal frame of reference of another with accuracy and with the emotional components and meanings which pertain hitherto, as if one were the person, but without ever losing the as if condition. Thus it means to sense the hurt or the pleasure of another as he senses it, and to perceive the causes thereof as he perceives them, but without ever losing the recognition that it is as if I were hurt or pleased, and so forth. And this as if quality is lost. If this as if quality is lost, then the state is one of identification. So essentially what he's saying here is, right, what it means to empathize with someone is to take on their frame of reference, to experience things in the way that they do. And this might involve feeling the way that they feel or perceiving what they perceive. But in each case that you do this, there has to be what he calls this as if quality, which he doesn't really clarify much, at least in this quotation. And if you lose as if quality, then he says, then we're talking about a whole different phenomenon, and that's identification. So he begins to kind of draw some boundaries around what he's calling empathy here. So this became a fundamental concept that was used among nurses, and Rogers was referred to very often in the early literature in nursing. So if you look at the literature in the 60s and 70s and so on, you can find plenty of references to Rogers' work on empathy. But not all nursing scholars were on board with this idea. And as nursing kind of began to kind of take its own shape and form into its own kind of distinctive discipline, then some nursing scholars started to recognize that this was a bit dangerous. This practice of just borrowing concepts might not be the right way to go. So I think a really good example of this is an article by Janice Morse and her colleagues. And this article isn't specifically about empathy, it's about concept development in nursing. And they say here, nursing as a profession is perhaps more unique than we have previously recognized. And this uniqueness has both advantages and disadvantages. One of the disadvantages is that we must develop our own practice, including our own interventions, cautiously and wisely rather than mimicking the therapeutic strategies of other professions. Conversely, the development of unique nursing theory and practical knowledge must be considered an advantage and essential as we develop as a distinct discipline. So she points out here that, look, there are many cases where another discipline has developed some kind of concept and we might want to take it into nursing, but it turns out that there's something distinctive about nursing that differs from this other field. And because the concept was designed in order to address an issue in that field, the concept doesn't necessarily work when brought into nursing, right? It might look like it does at the start, but if we think really carefully about this and we think about the distinctive differences between nursing and this particular field, then we might realize that the concept doesn't really fit within nursing. And Morris and her colleagues argue that nurses would actually be better off by kind of taking a step back and doing the hard intellectual work of developing their own concepts that are concepts specifically tailored to the kinds of issues the nurses are concerned with. So if we think about this in the context of empathy, we might say, look, Roger's concept of therapeutic empathy, that was meant to help us understand the specific kind of empathy that a psychotherapist uses in order to better understand and treat their client. But that's not the same kind of understanding, the same kind of empathizing that a nurse necessarily needs to have with their own patient. So we need to think carefully about what's distinctive, what's unique about the relationship between a nurse and her patient that we should kind of take seriously here. And let's develop a concept that does that kind of work. So I think that this is a fairly pointed criticism. I think it's an important concern that Morris and her colleagues express here. But there's a certain distinction that they don't make in this article. And this is something that Zahabi and I have pushed in our work on empathy and nursing, is that we need to draw a distinction between two different sources from which you might borrow concepts. Right? On the one hand, you can borrow concepts from other applied disciplines. And on the other hand, you might borrow concepts from other theoretical disciplines. So let's think about what the difference is there. In the case of borrowing concepts from another applied discipline, those concepts are often developed to make sense of a phenomenon as it manifests in a particular context. So again, for the sake of simplicity, we'll use Roger's concept of empathy here. His concept of empathy was specifically designed to help us understand the nature of empathy as it manifests in a psychotherapeutic encounter between the psychotherapist and their client. It wasn't necessarily meant as a concept that was supposed to help us understand empathy in all its forms or empathy in any kind of context. It's a specific kind of empathic encounter that Rogers wanted to understand and describe. So, of course, it might be a concept that ends up being broadly applicable, but that would be kind of an accident, right? The purpose of the concept as he had developed it wasn't to be broadly applicable. It wasn't necessarily for that purpose. But if we think about the way that concepts are developed within more theoretical disciplines, and here I'm thinking of things like psychology, or at least fields of psychology that aren't necessarily applied. So for theoretical psychology, for instance, the cognitive and neurosciences. We can also think about, for instance, certain fields of physics, theoretical physics. I'd also include many of the humanities here. Philosophy, certainly, I would count here as what I'm calling a theoretical discipline. And in these disciplines, when you develop a concept, you're not typically trying to understand how some phenomenon exists or manifests in a particular context. You're usually trying to understand it at a much more generalizable or universal level. So if a cognitive scientist is trying to understand empathy, they're not usually trying to understand what empathy means for a psychotherapist, or what empathy is in a psychotherapeutic encounter. They're not trying to understand what empathy is in the encounter between a nurse and their patient. They're trying to understand what empathy is in general, right? What empathy is for anyone. And this has both kind of positives and negatives. I think on the positive side is that if the concept is in fact well developed, and it accurately captures the phenomenon that it's trying to capture here, then it should in principle be applicable to a wide variety of topics and disciplines. Now, on the other hand, the downside, the negative, is that because these concepts are usually described at such a kind of abstract or theoretical level, it's not always immediately obvious how exactly we can apply this concept to a particular field. There usually is a lot of work we have to do to figure out, is this concept applicable to this field? If it is, how can it be applied? How can it be useful? And so on. So Zahavi and I have argued that we need to draw a distinction between borrowing concepts from applied disciplines and borrowing concepts from theoretical disciplines. And we argue that yes, nursing scholars and nurses should be wary of borrowing concepts from other applied disciplines because there's always a serious concern about a lack of fit. But they shouldn't be so concerned about borrowing concepts from theoretical disciplines. Those are more likely to be useful within the particular context they want to use it in. because they're supposed to be broadly applicable. So if we look at how the kind of debates around empathy have shifted in nursing over the past couple decades, they have moved away from using Rogers' concepts, at least using it as much as they did before. And they've started using concepts that have arisen from more recent debates in psychology and in the cognitive and affective neurosciences. And two of the concepts they end up using, among others, are emotional empathy and cognitive empathy. But these two concepts seem to be the ones that receive the most attention. Right? And these concepts also receive a lot of attention in psychology, a lot of attention in the cognitive sciences, a lot of attention in philosophy. So one good thing about nursing drawing on these concepts is that it now brings them into a shared interdisciplinary debate, and it becomes easier to kind of engage with researchers from other fields because you have a shared set of concepts. But Zahavi and I have argued, though, that there's an important sense in which these concepts don't really capture what it is that nurses should be concerned with, and they don't really solve some of the problems that nurses were concerned with when they wanted to have a more useful concept of empathy. So just to introduce these concepts very briefly, I know that, of course, many of you are probably already familiar with these from previous talks or from your own work. So emotional empathy, we can just kind of define in a cursory way as empathizing with or understanding another person by sharing their emotional state, right? Or feeling the way that they feel, right? So this is the kind of feeling with. So I understand someone else's anger by also feeling angry. I understand someone else's sadness by also feeling sad, and so on. Cognitive empathy, on the other hand, is usually referring to some kind of higher level cognitive function that we use in order to make sense of someone or understand someone. And there's a variety of tools and techniques we might use here that nurses tend to refer to under the broad heading of cognitive empathy. But one thing they often refer to is imaginative perspective taking, right? So if I want to understand someone else's experience, I kind of step back and imagine myself in their place. And through this process of imagination, I can kind of bring myself into their perspective, and I can now understand them. So in the current literature on nursing, especially if you're looking at the literature on nursing education and training, the kind of weight of this is more than cognitive empathy. So there are some concerns among nurses that emotional empathy is sort of problematic because it might be overwhelming, for instance, right? So if your patient is in extreme pain, the goal shouldn't be to empathize with your patient by feeling what it's like to be in extreme pain with them, or feeling their pain and taking it on yourself in some sense, because this would be distracting, and it would be overwhelming if you had to kind of emotionally share in all of your patient's feelings, since many of them might have very distressing emotional states they find themselves in. Cognitive empathy, on the other hand, is usually characterized, at least in the nursing literature, as something that's more kind of detached and objective. So you can understand another person without necessarily feeling what they feel. So you're not going to be overwhelmed by understanding them or by empathizing with them. And also cognitive empathy, because it's a higher level cognitive function, it's usually characterized as something that can in fact be trained. Whereas in a lot of the nursing scholarship, emotional empathy is characterized as something that can't be trained. There are a few who argue that it can, but for the most part, the idea is that cognitive empathy is the one that can in fact be trained. And if what you're concerned with is redesigning approaches to nursing education and training, then cognitive empathy is the one you're going to want to focus on here. So we've argued that neither emotional nor cognitive empathy really capture what it is that we need here. So there's, right, going back to this idea of wanting a mature concept, one thing that the field of nursing seems to want is some kind of shared or unified conception of empathy that can kind of bring the field together, so we don't end up with all these disparate little research projects that can't necessarily engage with each other. Now, because there are so many concepts of empathy in use, some have just suggested to say, hey, look, we're not going to agree on which of these is the best concept. There are way too many concepts that are currently in use. Lots of people are already kind of very much embedded within some of these concepts for their own research programs. But what we can do is that whenever we do a study, we have to, examine the various concepts that are available and we select the one that seems to be most applicable or most valuable to the particular study we're going to do. Now, I think that solves one problem, but it doesn't really resolve this issue of having some kind of unified framework or unified conceptual scheme that all nurses are going to use. You still end up with a bunch of kind of research programs going off in different directions. And if you have two studies on, say, the effectiveness of nursing or of empathy training in nursing, then you might end up in a situation where one of those studies uses one concept of empathy, another study uses a different concept of empathy, and they just become kind of incommensurable. You can't really compare them. You can't identify which one is better. So what Zahavi and I have suggested is that nursing scholars should in fact kind of take another step back. And while they should borrow concepts from theoretical disciplines, they should start by taking concepts that help them understand these phenomena at the most fundamental or basic level. So we introduce the phenomenological concept of basic empathy here. And the way in which we use this term, at least the way in which we, there's a lot more you can say about it, but the way in which we introduce it in the nursing literature is to say, look, the concept of basic empathy really refers to two things, or two kind of basic capacities that all human beings have. One is the basic capacity to perceive other human beings as expressive subjects rather than as mere objects. And the second feature of it is that it's the capacity for us to perceive what a particular subject is expressing, right? So I don't just see you when I have, like, say, a face-to-face encounter. I don't just see you as an expressive subject, but I see you as immediately expressing, say, embarrassment or shame or anger or tiredness. And right, I can't help but to understand you in this way. So phenomenologists often use the term basic empathy as a synonym for other perception, right? It's just the basic ability to perceive another human being as an other, that is, as a subject rather than as an object. So, right, when you shrug, or when you, clench your fist, or when you raise your voice, I can't help but to perceive all of those things as meaningful, as expressing something about your desires or your intentions or your emotions. And that's just the natural way in which we experience other people. And this is something different from both emotional empathy and cognitive empathy. Right, I think it's pretty clear how it's not cognitive empathy because it's not this higher level cognitive function. But it's also not the same as emotional empathy because it doesn't require that you feel with the other person, right? If I perceive someone else as angry, I don't necessarily have to feel anger in order to understand them as angry. In fact, I might feel something very different. If someone walks up to me and seems angry, I might immediately feel fear. But I feel that fear precisely because I already understand them as angry. So it's not my feeling with, it's not my emotional state that allows me to understand them. Right? My emotional state is often a reaction to my understanding of them. So once we've clarified this, there's now that question again that I had mentioned earlier. One of the difficulties when you start appealing to theoretical disciplines as opposed to applied ones is, yes, it's clear that the concept kind of fits nursing, right? If this is a concept that characterizes how any human being makes sense of another person, then obviously it characterizes how nurses experience and understand their patients. But why is it important, right? What value does it have? And especially if it's something that every human being already does, then why should nurses really pay attention to this? So I'll just go over this briefly, and we can spend some more time in the Q&A on this. And I also have some further reading on the final slide if you want to look into any of this in more detail. But we actually don't argue that basic empathy is the kind of thing that can be trained, or even should be trained if it could be necessarily. So we do think that cognitive empathy can be trained, right? You can train someone, I think, to be better at something like imaginative perspective taking. But basic empathy can't be trained. So why should nurses be interested in this in the context of, say, nursing education? Well, we think that basic empathy can, in fact, be obstructed, despite the fact that it can't really be trained. And if it can be obstructed, then we should be able to learn techniques to kind of unobstruct or remove some of these barriers to basic empathy. So when we're thinking about obstructions to basic empathy, that might be something like biases or prejudices you have, right? If you're engaging with someone and you already have various assumptions about the kind of person they are, you can easily misread or misinterpret the expressions that they mean to be giving. And on top of this, if you say approach someone with a fairly clear theoretical framework, right? In this case of a nurse or a physician interacting with a patient and trying to say perform a diagnosis, they might already have some fairly high-level theoretical frameworks they're using in order to understand this person, and that can get in the way of really allowing the person to genuinely express what it is that they're feeling or what issues they are in fact having or trying to convey to their healthcare provider. And also in the case of things like imaginative projection, or imaginative perspective taking, right? That imaginative perspective taking involves a certain kind of projection, right? If someone comes in and complains of a particular issue, and maybe you also complained of this issue at some point in your own life, and you now say, oh, well, I can kind of project myself into that situation, and I know exactly what you need. It might be the case that they are suffering in exactly the way you suffered or felt exactly the way that you felt. But it may also be the case that you've just kind of overridden their attempt to actually accurately express themselves, and you've just projected your own perspective on top of theirs. So we suggest that actually what might be helpful here is cultivating a kind of attitude of empathic openness. And we haven't articulated this in considerable detail, but it's something I'm happy to talk more about. But ideally, the idea here is that an attitude of empathic openness is one in which you retain a level of humility about the ability to, say, apply your own theoretical knowledge to certain cases, to admit that, yes, I see you as expressive, but I might also be projecting something on top of that. I might be seeing something that's not there, or I might be kind of forcing an interpretation of your expressions that isn't necessarily what you wanted to express. So in this respect, you might actually want to refrain from something like imaginative projecting or imaginative perspective taking in order to take this step back and allow yourself to perceive someone through basic empathy without trying to use the higher level cognitive functions immediately to kind of get in the way of that. Which is not to say, of course, that cognitive empathy is never useful. We agree that in many cases it might be. The concern is that it might override or get in the way of how we could understand someone through basic empathy in the first place. So I will end there, but thank you so much.